Hello, my name is Meredith Shimp. I am going to be taking you all through the lower extremity anatomy, and today we will be focusing on the hip. When Trent and I first discussed me making these videos, I really reflected on what was the most helpful for me in terms of learning this higher anatomy and being able to use it with my patients right away. And really it came down to clinical examples. So if I had a clinical example that allowed me to tie those two things together, I was able to learn it much more easily and start using it right away. That is really going to be my biggest goal here, is to give you the high level of anatomy, but also give you a clinical example as much as possible so you can start using the information tomorrow. And in order to do that, I will not be speaking to every single thing on the slide because you would be here forever, but come back and look at it and the information underneath as well. The lower extremities' two basic functions are to allow us to walk and to support our body weight. So in order to do that, you've got the ground reaction force coming up through the foot. You also have the stress from the upper extremity and the spine coming down through the SI joints and into the hips. Active hip motion is most of the time paired with pelvic motion and lumbar motion, which is really essential to keep in mind when you're looking at active hip motion in your patients. Specifically looking at the position they start in is going to give you a good clue as to what that true hip motion is. So if they're in prone and they have a little bit of a stomach on them, they're really in some hip flexion to start. So some hip extension may only get them to neutral, not true hip extension motion. This is another way you could look at hip flexion. So in supine using the straight leg raise. This top picture depicts the ideal scenario. The rectus abdominis is turning on and is stabilizing the pelvis. Therefore, when the psoas turns on, the leg raises effectively. As opposed to this bottom picture where the rectus abdominis is not turning on appropriately. Therefore, when the psoas turns on, it creates that anterior pelvic tilt. The leg does not raise as well, and you see that arching in the low back. If you see this in the clinic, that should really clue you in to add core stability exercises to this patient's regimen. Same idea here with hip ab and adduction. So even though we are assessing left hip abduction, you're also getting right hip abduction and lateral side bending. Internal and external rotation of the hip, we want to always assess this in prone or in neutral. The reasoning for that is where the ligaments are taut. So in the hip, all the ligaments are taut in that position, so we'll get a true feeling, as opposed to in hip flexion, where all the ligaments are slack, so it will look like they have a lot more internal and external rotation than they truly do. The anatomy of the femur is such that we need this complex trabecular system in order to not get a fracture through the neck of the femur. All of these different bundles are put down because of the different stress that's coming through the hip, right? That stress up and down that we just talked about. So number 1 and 2 are considered the primary trabeculae, and 3 and 4 are the secondary trabeculae. So number 1 is the arcuate bundle, and it is responsible for tensile stress. Number 2 is the supporting or cephalic bundle, and it is responsible for compressive stress. So these bundles create Gothic arches. So this picture is a little easier to see, so that where the Gothic arches come together, create this area in the middle, which is considered the zone of weakness because it is not supported by the trabecular system. So this is the area where you will most commonly see fractures. The femur has lots of different variations. Somewhere around 125 is a normal angle. Greater than 125 can be considered coxa valga. Less than 125 can be considered coxa vara. What I find specifically interesting is these potential functional adaptations that you can see that really allow for either mobility and speed or strength and reduced motion. So this slide is depicting the different femoral anaversion angles. And this is something that I think is well understood by most physical therapists, but what we don't understand is when we should be looking at this. When is this a factor? So in the clinic, if I'm looking at a patient in prone at their passive internal and external rotation range of motion, if they have full internal rotation range of motion and almost no external rotation, or vice versa, that's when I would look at this. So keeping them in that position and doing Craig's test would allow me to see if the angle of anaversion is a factor. The acetabulum faces anterior, inferior, and lateral, and that angle varies from 30 to 60 degrees. When I think this is specifically important is with your manual interventions. So if you are doing hip distraction and you are getting feedback from your patient and they are not reporting that deep capsular stretch, instead of just giving up, change your angle. So move a little bit more superior, inferior, lateral, depending on your starting point, and try again. This is when it's really important to have an open dialogue with your patient, and they will really have great buy-in when you get to the point where you get that deep capsular stretch. And then in this picture, we are looking at the angle of Weberg, which is 30 degrees. And this angle is the part of the acetabulum that overhangs the femur, which is where most of our weight bearing is happening. So in this area, the fibrocartilage of the labrum is the thickest here to accommodate for that. And this is the anterior superior part of the acetabulum and the superior lateral portion of the femur. If you have a patient that is coming to you and they're standing in anterior or posterior pelvic tilt or hip flexion, most likely they are not weight bearing through that optimal part of the hip. So that could be something to consider as a potential pain generator for them. The articular capsule creates that awesome vacuum seal in the hip, actually to the point that even if the muscles and the ligaments were removed, the hip would not dislocate. And what these different bundles are doing is kind of similar to the trabecular system. So they are resisting the different forces put on the capsule. In this picture, we are looking at the T1, 2, and 3. So these are different bundles or different origins of the rectus femoris. And specifically T3 is going to join the anterior hip capsule. And why is this important clinically? Well, it's really cool, first of all, but also if you have a patient that has L5-S1 fusion, or maybe they have pretty severe spinal stenosis, and you're trying to get them to be able to stand upright so that gravity isn't really taking such a toll on them when they're just standing, well, you can only do so much in their lumbar spine at that point, right? You can change a little bit, but maybe not that significant. So that's when you really want to look at the hip. So you could be doing anterior hip moves to help them stand upright, but also maybe you want to try to increase the length of the rectus femoris to get them a little bit more space there. There are 3 main ligaments in the hip. The iliofemoral ligament, the superior part of that ligament is actually the strongest in the hip. There is the pubofemoral ligament, and then the ischiofemoral ligament, which starts posteriorly and actually wraps around the neck of the femur and attaches to the anterior part near the greater trochanter. Now we are going to go through when the ligaments are taut versus slack in the different hip motions. And this is important because if you have a patient with non-contractile pain, so they don't have pain actively, but they do passively in a motion, the ligaments could be one of the pain generators. I think the easiest way to remember this is if you think of where the head of the femur is going in the motion, that is where the ligaments are taut. So in hip extension, all of the ligaments are taut. In hip flexion, they are all slack. External rotation, the anterior ligaments become taut and the posterior ligaments become slack. And then it's the opposite for internal rotation. For abduction, this pubofemoral ligament is becoming taut and the ischio and iliofemoral ligament become slack. And again, it's the opposite for hip adduction. Coaptation is talking about the degree and what forces are contributing to keeping the femur in the acetabulum. So this picture here is talking about the articular capsule that we already discussed, that vacuum seal. Here we're talking about gravity. So gravity actually assists with keeping the hip joint together. And then besides that, there are the muscles and the ligaments, and they are actually reciprocally balanced. So the anterior portion of the hip has strong ligamentous structures, but few muscles. The posterior side of the hip has robust muscles, but few ligaments. And the muscles that are really responsible for coaptation is the piriformis, the obturator externus, and then the glute med and the glute min. So this is something to keep in mind if you have those hypermobile patients, maybe somebody with Ehlers-Danlos. So the ligaments are really not doing their full part technically to support the hip. So you want to get the muscles even stronger so that they can overhelp because the ligaments are underhelping technically. And then also after a total hip replacement, if these muscles have been cut through or maybe they're just not turning on like they're supposed to, at that point you want to make sure you get them activating to try to prevent a dislocation. The primary hip flexors are your psoas, your iliacus, sartorius, rectus femoris, and the TFL. And then there are a lot of secondary or accessory hip flexors that we will go into more in a little bit. I wanted to take a second to talk about the origin of the psoas while we were here. So the psoas originates from the anterior aspect of the transverse processes of L1 to L5, as well as the anterior medial aspect of the lumbar discs and their corresponding vertebral bodies, except for L5-S1. So this is super essential because obviously it's so closely linked to the lumbar spine. So if there's been a surgery here, especially maybe a more invasive surgery like a fusion, you want to be asking yourself, did the psoas get cut through at all? Is it able to turn on like it's supposed to? Is there pain there because there's a lot of guarding and potentially this muscle is compressing those nerve roots, creating some sort of neural tension? Is it just pain from guarding and perfusion would help? Is it tight versus weak? There's just a lot of factors to consider when it comes to the psoas. Your hip extensors, so the glute max is number 1 here, and that is actually the most powerful muscle in the entire body. And then you have the glute med and glute min. And then you also have the hamstrings and the adductors, that the degree of effectiveness is based on the knee position. So if they are in knee extension, then they're going to be able to extend the hip more easily. This picture is going through what those hip extensor muscles are doing depending on that pelvic position when you're standing on both feet. So in the highlighted one, this is equilibrium. And then if you go into a little bit of an anterior tilt, you get the hamstrings turning on. And then the further you go, you also get the glute max turning on. So if you have a patient that presents in standing in an anterior pelvic tilt to start, these muscles are turning on just to keep them upright. So that's just something to consider in terms of their pain generator. Could you get some of those muscles turning off depending on their starting position? Hip abductors. So the glute med is the main hip abductor, and it works so efficiently because it is perpendicular to the lever arm. And the glute med and the TFL are responsible for stabilizing the pelvis. The 2 types of abductors are your trochanteric abductors, so the glute med and the glute min. And then you have your IT band tensioners, so the TFL and the upper glute max, both attached to the IT band, and they have this synergistic relationship when they co-contract to create that pure abduction. So if you have someone on their side and you ask them to abduct their hip and they go into more hip flexion, one of the possibilities there is that this synergy is a little bit off balance. So the TFL could be doing more work and the upper glute max might not be turning on enough. I put these here more as a reference for you all, but I'll touch on it. So lateral hip pain is super common, but not that well understood. So this study looked at 40 people with hip pain and 40 people without hip pain, specifically lateral hip pain. And they looked at them under an MRI to see what they found. One thing to note, of course, is that these asymptomatic hips showed lots of pathology on the MRI. So just because there's something there does not mean there has to be pain. But also the ones that did have pain, more often than not, had more than one thing going on. So they had tendon pathology, bursitis, and OA. And the most commonly irritated or implicated tendon was the glute med tendon. So there are up to 20 bursa in the lateral hip, but the most common ones are pictured here. So C is this trochanteric bursa or the subglute max bursa. B is your subglute med bursa, and A is your subglute min bursa. And this picture really shows you why there is normally multiple things that are implicated in the lateral hip, because what's irritating it is compression through the IT band. And all of the structures live right under this greater trochanter area. So the bursa are there and all the tendons. So in this picture, you have a lateral pelvic shift, and that's creating the hip, the femur to go into a little bit of adduction, which is increasing the compression through the IT band. And the same thing is happening here with a lateral pelvic tilt. This slide goes into the positions that are going to increase that compressive force through the lateral hip. So if you have a patient coming in and on their eval, they have greater trochanteric pain syndrome, if you can spend some time on patient education, you're really going to set yourself up for success for their plan of care. All of these different positions are increasing that pressure. And specifically sleeping, we spend a lot of time sleeping or trying to sleep. So the position that they're in is super important. If they're in this position, that's going to really be increasing that compression. This would be a neutral position. This would really be the most ideal. So you're getting that knee above the hip to decrease the compression through the outside there. And even if you have a patient that says they sleep on their side with a pillow, making sure they know that it needs to be thick enough to get that knee up, because a lot of times it's still in a little bit of adduction. And then this picture goes even more into that lateral shift. So there would be an increase in compression on the lateral hip here. And then the adductors would be working more on this side, and the abductors, which would be working more on this side. So if you did single leg stance here, they would most likely be better able to do it on the right leg and not able to do it on this left leg. So in terms of single leg stance, in equilibrium, these are the muscles that are stabilizing. So the glute med, the TFL, and the glute max superficial fibers are stabilizing. So if you have a patient that is unable to stand on one leg in general, and they can't do it as an intervention yet, these are the muscles that you would want to target to allow them to work towards being able to stand on one leg so they can get dressed, for example. And then if they want to progress a little bit, if you go into a little bit of anterior pelvic tilt, you're going to get those deep glute max fibers, and then you also get the piriformis the farther you go, as well as the obturator internus. The hip adductors. So this top picture is the adductor magnus, which is the most powerful of the adductors, and it has a different orientation so that it is able to adduct the hip from any degree of abduction. And these hip adductors also produce hip flexion and hip extension, which is dependent on their specific origin insertion, but also where the leg is in space. So at neutral, all of the adductors except the posterior fibers of the adductor magnus are hip flexors. And the farther we go up, they start to turn off and become hip extensors. So at 40 degrees, the gracilis becomes an extensor. At 50 degrees, the adductor brevis becomes an extensor, and at 70 degrees, the adductor longus becomes an extensor. And then when you get to maximal hip flexion, they are all extensors. One time I think this is important to keep in mind in the clinic, is somebody that has had a total hip and they're having groin pain getting in and out of bed because they're trying to lift their leg and it's really pulling on that groin area. That could be referred pain from the hip, but it also could be because the main hip flexors were traumatized during that surgery. They may not be turning on as easily, so the adductors are taking on additional stress. So you can almost get like a tendonitis and definitely can get trigger points in the adductors in these patients. The external rotators, so these are some of the main muscles of coaptation that we talked about, but they are just so essential in stabilizing the lower extremity. So they stabilize from the hip, but then it's also so important for the knee and the ankle as well, the foot. And if you have your leg extended and you externally rotate from the hip, the knee, and the foot all together, so a longer lever arm, the hamstrings and adductors also externally rotate. Internal rotators. So the internal rotators are only a third as powerful as the external rotators, and the anterior fibers of the glute med and the glute min and the TFL are the main ones that are working. And so similar to the adductors, depending where you are in the range of motion, it's different which muscles are functioning. So 30 to 40 degrees of internal rotation. The obturator externus and the pectineus actually stop externally rotating, and the glute med and the glute min are still internally rotating. And then when you get all the way into internal rotation, the obturator externus and the pectineus are now internal rotators, and the TFL, glute med, and glute min become external rotators. Okay, so I included these slides. They're in your orthopedic residency manual presentation as well, but I just think they're super helpful in terms of innervation and these, like, in general for the movements. So if you had done manual muscle testing for the hip with a patient and you noticed that their hip flexion was specifically weak as compared to the rest of the motions, you could come here and see that L2, L3 is the main levels that innervate these muscles. So you could ask the patient if they had had any kind of lumbar injury in the past, potentially a surgery. Is there a reason these muscles may not have been innervated properly? And then is there anything you can do with your interventions to change that? So you can just look through these as a reference. And that is it. I hope that you all enjoyed this and that you learned a lot and my examples were helpful, and I will see you at the knee.